So we're here at ISNTD Co-Infections and Comorbidities. Fresh from running the London Marathon, we have Professor Tim Allen from London School of Economics. Tim, you've given an excellent presentation this morning in terms of some of the pitfalls involved in evaluation and impact of deworming. Would you like to just elaborate a little bit on that?
Well, I think you've used the term deworming, and I think that in itself is a problematic term because under this label of deworming occurs treatment for a wide variety of different diseases. I mean, even if we're referring to soil-transmitted helminths, these are very different to one another. But also, in many of the deworming studies, we're combining treatment for soil-transmitted helminths with albendazole, together with treatment for, say, schistosomiasis with praziquantel. Very different diseases with very different etiologies. So that's one issue. So we get these general discussions about deworming, which mask what's really being investigated. That's one problem. Another is that so much of the discussion about the effectiveness of deworming, and in particular school-based deworming, and specifically school-based deworming in Africa, which has been so influential in the debates, is related to a paper that was published by two very well-known economists, Miguel and Kramer, in 2004, but in fact circulated in draft form for many years before. And that study, which is actually based on research done in the late 1990s, is the most cited paper to justify the massive expansion of school-based deworming. I mean, it's mentioned in almost every key World Health Organization statement about the rolling out of deworming. Very often, it's the only piece of evidence that's provided. Miguel and Kramer, very honestly, and very transparently, made their data set available. It's available for everybody to look at. And a group of scholars have looked at the data and have reanalyzed it and have noted that, in fact, the results are not those that were presented in the published paper. That it's perfectly reasonable to conclude from a reanalysis of their data that deworming, even of that group of children in the late 1990s, had no discernible effect at all.
And I know that paper was picked up with the Cochrane reviews and everything, and underlined again by separate group.
Exactly.
And you mentioned that in your presentation as well.
Random control trials have suggested that large-scale deworming, it may have an effect, but it doesn't get picked up. It appears from the data, the macro data, that school-based deworming has no effect.
So applying that, and I'm saying this because you have a pedigree in terms of blazing a trailblazing in terms of getting standardized, set in stone approaches such as the MD. We're talking about mass drug administration. In lymphatic filariasis as an example, you've set quite a trail in terms of getting the MDA community, be that pharma, big pharma, the MOHs, the evaluation teams, the academics involved, to re-examine the nuances of the MDA model and actually look at it from a different perspective. So what would be, my question I guess is, what would be your recommendation to anybody involved in a large MDA program in these areas? What would your recommendations be? What should they do differently?
It's hardly the most shocking thing. I would say, let's not be frightened of evidence. Let's have a look at what's really happening. Rather than have a debate about an old data set from the late 1990s and whether or not the econometrics should have been done this way or that way, let's ask, for example, are children in African primary schools receiving the medications? Because if they are not taking the tablets, it's definitely not going to have any effect. I mean, there's also the issue of, well, are they still infected? Have infection rates gone up or down? Have school enrollment rates increased? I mean, there's all sorts of work that could be done, and remarkably, it's not done. I mean, we've now worked in numerous sites across Tanzania and Uganda, and we've collected data from a very large number of schools. And the answer to my question is, well, actually, treatment in schools is often much better than in the population. It varies. Sometimes it's very low, but often it's much better than the kind of community distributions. But it's haphazard. Sometimes the wrong drugs arrive, sometimes the wrong combination of drugs arrive. And by and large, it's below the targeted rates. I mean, on average, about half the population of children in a population probably get the tablets. So there's all sorts of issues to ask about that, about, well, is it really a sensible program to keep giving children albendazole, for example, for soil-transmitted helminths, if they're immediately going to reinfect? Is that really a beneficial thing to do? And we ought to have more information about that, because it's clear they reinfect. So there's that sort of information. I suppose the other issue that I would raise, which is perhaps a little bit less about the evidence and more about my own concerns, is that overwhelmingly the children that we have seen, we've observed being treated since 2005 in schools have been treated without the children or their parents knowing why they're receiving these tablets. Now, I wouldn't suggest that it's possible, to get the written permission of all African parents that they, for their children to be treated. But it is deeply problematic for me that we have a program that is based upon mass treatment of children in school, actually without their parents' informed consent, or even knowledge. And I do ask, where else in the world would that be possible? I think that's deeply problematic.
And I suppose it also, if it wasn't the case, if consent or some kind of communication channel was open with the parents, that would only augment the overall workings of a healthcare system in that area, because you'd have some form of patient record, some form of other information coming into the overall repository in terms of the patient. Look at the actual patients.
Yes, I mean, it would certainly improve the more general database, and it really ought to be part of general health education, shouldn't it? But I suppose if one's going to think about what it is we're talking about, it does indicate something quite revealing, doesn't it? I mean, we have this term, neglected tropical diseases, which is not a scientific term. It's a bunch of diseases that have been shoved into a category. I mean, not being cynical about it, but mainly for fundraising purposes, to highlight the importance of those infections, and they are important, and to try and raise money. But that term neglected, that term is a social term. It's a social term. And who gets neglected tropical diseases? It's neglected people. And so it's perhaps not surprising that there seems to be a sort of chronic incapacity to, let me put it bluntly, respect the population enough to engage them in their own healthcare. Yeah.
That's a fundamental point you've made there, and quite a profound point that you've made there. In terms of, I know you're head of the Department for International Development at the London School of Economics, and I'm sure you've got a lot of postgrad researchers or under your mentorship that are looking at this type of area in terms of generating mechanisms, generating evidence ultimately that could be used for policy or in this case MDAs as an example. What is your department doing to reach out and make that change with this MDA community?
With this MDA community?
Yeah.
Well, I suppose of all my colleagues, I'm the only one who's working particularly on mass drug administration. But I think that there's a broader issue about international development. I mean, it's probably true of all policy, but particularly when it comes to issues around international development, what drives policy tends not to be evidence. Particularly, it tends not to be the evidence from very poor populations. What drives policy is sort of normative assumptions about what would make the world a better place. It's stories that drives policy. And I think those kind of stories have rather sort of captured the MDA world in a somewhat unhelpful way, and we have to kind of unpack it a bit. I suppose sort of a general point I'd make about international development broadly, but I would say this also applies to any kind of healthcare, really, is sometimes very often it's not necessarily what you do, it's how you do it. It just makes such a difference. And there's been this big problem, at least in East Africa where we've observed it. I don't say it's the case everywhere. We were hearing this morning that perhaps in Zimbabwe it works differently, but in places in East Africa where we have observed it, that the buy-in from the population is simply not there. And people who are well-intentioned, in most cases, I assume, and I've seen they are well-intentioned, that they ascribe views to people and they make choices on their behalf, and it's perhaps not surprising that people withdraw. They withdraw. So this is the weapons of the weak, if you like, that you simply don't take the tablets. And we see that again and again.
Yeah, I mean, that's again a profound point, but I mean, economics or ethics, which is going to override the MDA equation and redirect it to a real position in terms of actual treatment, making a difference? In your opinion, will it be ethics, or will it be the ethical argument that you've just highlighted briefly there, or the economic case?
I mean, ethics is a difficult one, isn't it? Because we might choose not to do things for ethical reasons that may have social benefits. We all have our own moral compass, and I've raised the point about the ethics in that, if my little girl came back from school and she'd been given tablets by some strange people and she felt a bit sick, I would be pretty angry as a parent. And I worry that we feel it's possible to do that in Africa, but we can't do it in London. I find that problematic. In this particular case, we need a biosocial approach. We need to understand or learn from people who know about the biology and take that into account. And we need to understand and engage with social issues raised by economists, anthropologists, whoever. We need to look at the information that's available, treat it with rigor, with critical rigor, and on the basis of that we can move forward. I mean, one of the things that is simply not studied, because in a sense people can't even conceptualize it because of the way that people, because of the way these things are thought about, are the places where it works. We have found places in Africa where people take the tablets, where disease profiles have plummeted, and where people have buy-in. They're quite small areas, and often surrounded by places where it's not happening. So what makes it work? I mean, we shouldn't assume it works everywhere. Actually, in most places, it doesn't really work. But it does work in a few places. And it's almost like nobody is even asking that question because there's an assumption that it's working everywhere.
Yeah. I mean, what you're essentially describing as part of that answer is something the whole world has been shouting in terms of rhetoric, multidisciplinarism, multisectorialism. We've all got to, we're in it together, we've got to keep it all together. In essence, you're describing a place where that's happened, and the anthropologists are speaking with the pharmacologists, are speaking with the biologists, are with the microscopy people. How far away are we from that? Is it inevitable? Is it going to happen?
I wouldn't say it's that close, but it's going to keep me employed for the rest of my career, I think, managing that. I mean, I run a department of economists, sociologists, political scientists, anthropologists, and everybody has different ways, they construct knowledge in different ways, and I work with biologists and in the School of Hygiene and elsewhere. I thrive on it. I love to understand how evidence is constructed in other disciplines, and I feel if I can respect it, I can learn from it. This kind of disciplinary silos and the defensiveness with which people refuse to think through entrenched positions is so deeply problematic. And in this area where we're talking about the needs of deprived people, it's tragic. In fact.
And maybe the irony is it'll come from this togetherness or sense of bringing the silos down, actual multidisciplinarism will probably, it's quite ironic, it may come from the corporate sector. You've heard today Jamie Taylor from Janssen speaking about their holistic approach to NTDs, making partnerships. She's even mentioned leaning on consumer insights. You've heard Nestle say pretty much the same thing. It's quite interesting that that's coming from somewhere that you would not traditionally associate with a multi-sectorial, open arms kind of approach. So in a way, it's,
but I mean, in this world,
is it encouraging? Is it not? You know?
But in this particular context, we're talking about a whole program that's based on that, because the drugs are being provided free of charge. And I mean, there's all sorts of reasons why that might be the case, but that's what makes these programs possible. All sorts of interest groups have their own agenda. And I'm certainly not one to. I understand what you mean by holistic, and I get your point about working together, but I don't necessarily think we need, loving consensus. It's out of productive conflict that we generate new questions that enable us to produce kind of new knowledge which helps us understand the world better. It's not a smooth, consensus-driven process. It's conflict with respect.
That's a fascinating take on it. I'm actually quite optimistic actually after hearing that.
I'm always optimistic. We're moving on. We had an interesting, robust discussion today. Nobody walked out the room.
No, why should they?
People have different perspectives, and I think we learned a bit from each other, and that's how things move on.
Yeah, and I think it's very, very worthwhile. All of this, to say that you came here today to speak about this particular issue, and you've mentioned your presentation that you've got a paper about to be published with Melissa Parker from the NHSTM. What would you like to just elaborate a little bit on that?
Well, in fact, it comes from a meeting that took place a few years ago. We asked all the people, including people who we've had some quite robust discussions and debates with, to come together for a meeting on biosocial approaches to mass drug administration. And it was a fascinating meeting, and it's taken us a long time to extract papers from various people and to put them through a sort of rigorous peer review process. It's not been so easy to get the papers put together because the perspectives were so different, but we have managed to do that now. This paper that I've written with Melissa, which is frankly a bit of a doorstop, it's a very long paper in which we try to review all the available evidence we could get hold of on deworming of children in various parts of East Africa, and kind of look critically at it to think of where are we now, and we go into the econometrics and look at the problems with that, and we look at what evidence there is of children actually taking tablets in school. So it reviews all these issues. We have detailed studies of one particular area where mass drug administration seems to be effective, where intensity and prevalence of diseases appear to have declined. And we look into, the author of that paper, Georgina Pearson, is looking into, why is it the case there? On the other hand, we've looked at the collapse in programs in Tanzania at one point, with riots in schools, and looking at what happened there and why did parents react in that way. We've got a very nice paper looking at the use of health education materials and looking at precisely why they don't work. So it's a package of papers which we're going to be published in the next few weeks, and is going to be coming out in the Journal of Biosocial Science.
Fantastic. And I think that would be a hearty read, and again, it's the juxtaposition that's actually required. You need this to challenge the orthodoxy in terms of approaches, methodologies. It's needed. So thank you very, very much for making time. Hope you caught your breath from the London Marathon. I hope you had a time to rest before coming here. Perhaps I should have asked you that at the beginning, but thank you very, very much. Nice to see you again.
Thanks for having me.
Thanks a lot.